This week, we're looking at differential diagnoses. In looking at the three cases that we've been given, I'll review them, provide three differential diagnoses, the one I believe is most likely the diagnosis, and how I'm going to manage each patient. So for case number one, this is a 67-year-old male who presents with fever, chills, and confusion. His vital signs show fever, he's tachycardic, hypotensive, tachypnic, and has a O2 sat of 90% on room air. His exam shows coarse crackles in the bilateral lung fields and delayed capillary refill. So my three differential diagnoses for this patient is to consider his community-acquired pneumonia. Because of his fever, he's hypoxic, he's tachypnic, he has bilateral crackles, and his history of COPD and diabetes it dramatically increases his risk. The second is to consider is COVID because of fever, bilateral crackles in the lungs, he's hypoxic, and he's confused. And the third one to consider here is sepsis. He's likely septic from an infection somewhere else, potentially, could be a urinary catheter-associated infection. And I'm putting this in there because he has a fever, he's hypotensive, which is a strong indicator. He's confused. So the most likely diagnosis for this patient is a community-acquired pneumonia. I'm going to manage this patient by getting a chest x-ray, getting blood cultures before and after antibiotic administration. I would get a CMP, a lactate, a sputum culture, an ABG. I would also get an EKG. I would like to keep him on low O2 due to his COPD history. I would give him fluids and consider ceftriaxone and azithromycin once it's confirmed. Case number two is a 59-year-old female who presents with crushing substernal chest pain radiating to the left jaw and her arm. She's nauseated and diaphoretic. Her vitals are she's hypotensive. She's a little tachycardic. She is tachypnic. She does her risk factors, so she's hypertensive. She's obese, and she's a 20-pack year smoking history. Three differential diagnoses that I'm looking at for her is she having a STEMI? This is because of the substernal chest pain that's radiating to the left shoulder or jaw. She's nauseous, she's diaphoretic, she's hypotensive when she's normally hypertensive, and her strong history of smoking and obesity puts her at great risk for an MI. I would also look at an NSTEMI as well, without the ST elevation. I would look at an aortic dissection due to the crushing chest pain. Sometimes it radiates to the jaw or arms, and then she's hypotensive. And the third one is pulmonary embolism, which can present with sudden chest pain. She's tachycardic, hypotensive, diaphoretic, and she's nauseous. How I'd manage this patient is immediately get an EKG. And if the EKG shows a STEMI, I would notify the cath lab, access 2 IV sites, one on each arm, potentially, give her fluid. I would always consider looking at MONA, so morphine for pain, oxygen, if I can't keep her SATs above 90. I would look at nitrates, but I'm going to consider them cautious given she's hypotensive. And I would also look at sildenafils as a other concern, and aspirin, probably 325 milligrams that she can chew. Labs I would look at is getting a troponin, a CKMB, a CBC, a CMP, a PT-INR, and probably a PTT. I would also get a chest x-ray and consider norepinephrine if I can't keep her blood pressure above 100. Case number three here is a 72-year-old male who was brought into the ED with sudden right-sided weakness and slurred speech that began 1 hour ago. Vital signs are he is elevated blood pressure. He's normal heart rate, normal respiratory rate. He does have a past medical history of AFib, hypertension, and no history of seizures. The three diagnoses, differential diagnoses I'm looking at here is a CVA due to the slurred speech, the right-sided weakness, and his history of AFib, which puts him at risk for an emboli, as well as hypertension. I would also look at potential TIA and see if things resolve within a couple of hours, or potential head bleed, or intracranial hemorrhage, or from a hemorrhagic stroke due to his elevated blood pressure risk. And how I'm going to manage this patient is I would activate the stroke team, conduct a FAST score, determine his last known well time, usually the 4-hour window for TPA administration. I get a finger stick to check his glucose. I would do a CT immediately to rule out hemorrhagic stroke. And for the beginning of considering TPA administration, I want to look at when did the symptoms start, as long as they were less than 4 hours ago. Confirm that there's no intracranial hemorrhage. Get his blood, make sure his blood pressure stays below 185 systolic, that there's been no active bleeding or recent surgery or an aneurysm or history of aneurysm. If none of those have occurred, then I would consider giving alteplase or tenecteplase. And I would get a labs, CBC, a BMP, PT, INR, or a PTT. I would not wait to give the fibrolytics to get the labs. So my 3 considerations: case number 1, I feel like this is most likely community-acquired pneumonia. For case number 2, this is likely a myocardial infarction. And case number 3, it's most likely a CVA.